As a prelude, I just finished making this video, and I wanted to say at the beginning that it's way longer than I thought it would be, but I really go into depth covering hemostasis, primary hemostasis. The original objective was to cover DIC, and I do that towards the end. If you want to see that, skip to about 2/3 of the way through this video and start there. But in order to understand DIC and almost any disease and any pharmacology and any lab test with the blood, you need to understand in-depth hemostasis. And that's what I cover mostly in this video. Okay, we're going to look at disseminated intravascular coagulation, but in order to do that, I'll call this part 1. We have to take a quick look, a refresher look at the clotting cascade, both the clotting cascade and the formation of the platelet plug, so I'll do that real quick. Okay, the physiology of blood with clotting and everything, this is called hemostasis. And hemostasis, we usually divide it up into two things. We divide it up into primary and secondary, with primary being the formation of a platelet plug, and secondary being the stabilization of the plug with fibrin cross-linking. So the secondary hemostasis is basically the clotting cascade that we all dreaded learning in undergrad. But if you weren't a bio major, then I'll go ahead and recover that as well, and hopefully give you a few things to remember that. But there's a third thing I could add to this. So hemostasis, you could add a third thing, and that's called resolution or healing. And the idea behind that is whenever you talk about diseases of hemostasis, you can really break it up into diseases of two kinds. Diseases where there's a defect in the clotting, either primary or secondary, or diseases where there's a defect in the resolution of a clot or the slowing down of the clotting. And so what I'm talking about here, like you can have bleeding disorders, for example, hemophilia, where you don't clot, and you can have bleeding, or you can have clotting disorders, or also called thrombotic events, where you clot too much. And so then, last of all, you have disseminated intravascular coagulation. So if you think of not clotting and clotting too much as two ends of a pole, and where we want to be is like right here in the middle, and DIC is basically at both ends at the same time. So disseminated intravascular coagulation is like the bipolar hemostasis disorder. So we would call not clotting, we would call that hemorrhaging. And then we would call clotting too much a thrombotic event, or thrombosis. And then the bipolar we would call DIC. So primary hemostasis, in other words, the formation of a platelet clot, a platelet plug, is 4 steps. You can think of these as these 4 steps. First is vasoconstriction. It's pretty high yield. What happens here? We have our vessel. Let's say we get damage right here. Immediately, this part of the vessel is going to constrict slightly, and that's going to be mediated by 2 different things. It's going to be mediated by neurogenic and by chemical mediators. Next is going to be platelet adhesion, and adhesion is basically a platelet adhering to the surface of the subendothelial collagen. So we get a platelet in this damaged area, it's going to stick to the surface of this damaged area, so it's going to stick right there. Then it's going to degranulate, so degranulation is the release of some chemical mediators. Those chemical mediators are then going to feed back onto the platelet, and they're also going to feed onto other platelets, and those platelets are then going to be able to stick together. And that sticking together is called platelet aggregation. So remember that this is adhesion, this is aggregation, the release of the mediators is degranulation, and this contracting of the vessel is vasoconstriction. Okay, step 1 of primary hemostasis, step 1 is vasoconstriction. And again, I said this is a neurogenic reflex due to damage, so the nerve cells in the area relay messages back and forth to the smooth muscles, and there's some constriction. It's also mediated by endothelin. So when endothelial cells are damaged or traumatized, they release endothelin, and it is the body's most potent chemical mediator of vasoconstriction. So remember, endothelin is the most powerful vasoconstrictor that our body makes. Step 2 in hemostasis is platelet adhesion. And platelet adhesion is in the exposed subendothelial collagen, von Willebrand factor will bind to it. And then after that, the platelets will be able to bind to von Willebrand factor. So what is von Willebrand factor? Basically, it comes from two places. The endothelial cells store it in Weibel-Palade bodies. And Weibel-Palade bodies contain two things. Dr. Sitar gives a great mnemonic. The W, he remembers Willebrand, von Willebrand factor, and the P stands for P-selectin. So Willebrand, von Willebrand factor and P-selectin are the two main factors stored in Weibel-Palade bodies. And then alpha granules inside of platelets also contain some von Willebrand factor. You'll remember that inside of a platelet, we've got two types of granules. We've got the alpha granules, and we've got the dense granules, and they're also called delta granules. Alpha granules, basically, they will store von Willebrand factor, factor 5, and things like fibronectin for wound healing. And then for dense granules, there's going to be two main things you want to remember that they have in them. The first one is ADP. The second one is thromboxane A2. They also contain calcium, which is important. And they contain serotonin. And also epinephrine. But the main things you want to remember are ADP and thromboxane A2. And when we get to step 3, degranulation, the primary thing we're going to be focusing on is the degranulation of these dense bodies, or these delta granules. But I point out these granules now because I want to point out that we get some von Willebrand factor from these alpha granules, but most of it comes from the Weibel-Palade bodies. So here's the idea. If I'm inside of a blood vessel right here, this is an endothelial cell, this is an endothelial cell, this is an area that's damaged, and under here we have the subendothelial collagen. Now what we're going to do is we're going to go just below that, and we're actually going to draw in two more things. We're going to try to draw in some smooth muscle. We'll just call this smooth muscle wrapping around the cell. And then we're also going to say that we have fibroblasts. So the fibroblasts and the smooth muscle, I draw those in because they're going to be important when we get to the clotting cascade. These, whenever there's damage or exposure, they actually produce something called tissue factor. Now just keep that in the back of your mind. So we have tissue factor. That's going to be important later. And that tissue factor can either be on the cell surface or it can be free floating out in the plasma. But just keep that in the back of your mind. We've got tissue factor. However, first we're going to have von Willebrand factor. This is going to be my von Willebrand factor. Is going to bind to subendothelial collagen. And so after it binds, the platelet will arrive. We're going to draw the platelet as green. We get a platelet here. And let's go ahead and say that we have a couple of platelets. So we got a platelet there, we've got a platelet there, we've got a platelet there. And this platelet is actually going to be expressing something called GP1B. So this is a GP1B. And it's usually as a Roman numeral, but I like English numbers better. So the GP1B receptor actually binds to von Willebrand factor, and that causes that is adhesion. So that is step 2. Step 3 in primary hemostasis is degranulation. So we said that platelets adhere to von Willebrand factor, and that adherence causes the platelets to change their shape. So the platelets change their shape, and that does two things to the platelets. First of all, it increases their surface area, which is important for the clotting cascade. And the second thing it does is it causes them to release the dense granules. Now you remember I said that the two important chemicals that are inside of the dense granules are ADP and thromboxane A2. We also want to remember that there's calcium involved. But calcium comes in later. Calcium gets released, and it's important in the clotting cascade. So let's put this in the back of our mind just like we did with tissue factor. Remember the tissue factor from fibroblasts and smooth muscle cells, that's still in the back of our mind. It hasn't come into play yet. So the ADP and the thromboxane A2 act both autocrine and paracrine on the platelets and cause them to express GP2B3A. So you'll remember that I said that the dense granules, they degranulate and they release chemical mediators. And those chemical mediators will act both on the specific cell itself autochronally and on other platelets. No, I'm sorry, not the cell, it's a platelet. Platelets are anuclear. So it'll act on the platelet and it will act on other platelets. And it will cause GP2B3A to be formed on the surface of those platelets. And you'll want to remember that these granules are released through shape change. Now, if I were to ask you what is released from the granules, your answer would be ADP and thromboxane A2. And you'll also, in the back of your mind, calcium. So this is ADP and thromboxane A2, both act to cause the surface expression of the GP2B3A. And it's somewhat important to remember that these receptors are called GP2B3A receptors. Now the tie-in with pharmacology is with thromboxane A2, and you'll remember that thromboxane A2 is produced by cyclooxygenase. And so what happens is we'll have arachidonic acid inside of the platelet, and the arachidonic acid will be acted on by cyclooxygenase, and it will form thromboxane A2. And you remember that acetylsalicylic acid, or aspirin, is an inhibitor of cyclooxygenase. And so aspirin can inhibit cyclooxygenase and thereby preventing the formation of thromboxane A2. And whenever thromboxane A2 is inhibited, you have reduced expression of GP2B3A. So you reduce the platelet, you reduce the expression of GP2B3A, and that's going to be important in the next step, because GP2B3A is what allows for aggregation. And finally, the last step, step 4, in primary hemostasis is the aggregation of platelets forming the platelet plug. So remember, this is where we finally get the platelet plug. Okay, so after we have the GP2B3A receptors expressed, a plasma protein called fibrinogen can come in here and it can cross-link these receptors. And so those receptors now being cross-linked, you have a platelet plug that is formed. And so with that platelet plug formed, remember that this is done by fibrinogen. And fibrinogen holds the platelets together weakly. This is a very weak bond, and it needs to be strengthened. And so the next step, the secondary hemostasis, does two things. It comes in and it strengthens up this bond, making it really strong, and then it cross-links all these fibrin. The strengthening up of the platelet bond happens by converting fibrinogen into fibrin, and then fibrin can cross-link with other fibrin, forming a mesh. Again, so once the fibrinogen connects the platelets through the GP2B3A receptor, the primary is done. Secondary is the process of turning fibrinogen into fibrin and then cross-linking all of the fibrin to form a mesh. And so if we go back to the slide, it says that plasma fibrinogen links the platelets by connecting the GP2B3A receptors. The platelet plug is formed. It's weak, it can be easily destroyed, and the second thing is we want to remember that stabilizing occurs through secondary hemostasis. Last thing before we move on to secondary hemostasis, I just want to point out a few genetic diseases that are associated with primary hemostasis. So a defect or deficiency in von Willebrand factor, that's simple, it's called von Willebrand disease. A deficiency in GP1B receptor is called Bernard-Soulier, and a defect or deficiency in the GP2B3A is called Glanzmant thrombasthenia. Now, as a rule, when there's a defect in primary hemostasis, what you're going to see is mucosal bleeding and petechiae. So if you had von Willebrand disease, if you had Glanzmant thrombasthenia, or if you had Bernard Soulier, you could look for things like mucosal bleeding, so nose bleeding, or coughing up blood, hemoptysis, GI bleeding, bleeding from the gums. Those would be mucosal surfaces. Then you would also look for petechiae. Also, in things that aren't genetic, for example, if somebody for some reason they have an infection, it causes an extremely low platelet count. A low platelet count would also be a cause of primary hemostatic disorder. And the number one thing you worry about, I don't know how common it is, but the number one thing you worry about with a low platelet count is intracranial bleeding. Secondary hemostasis, I said, is converting fibrinogen to fibrin and cross-linking the fibrin to form a mesh. And so I've already explained what that means, and so we'll go on. So let's go over the clotting cascade, coagulation. This is one of the better pictures I could find because it covers enough detail and there's enough simplicity, but there's an even better one I put in the study guide, so look there on box. But I'm going to try to explain this to you in a stepwise fashion. So you'll remember that X marks the spot, or if you like the Olympics, then you'll remember that everybody wants a 10. And in the initial part of the clotting cascade, everything we're trying to do is get to 10. So we'll start with 12, 11, we already have 10, so we'll go to 9, and then we'll go to 8. So we have 12, 11, 10, 9, 8. Then over here we can put a 7 and a 3, because 3 plus 7 makes 10. And then at the bottom we can put 1 times 2 times 5 makes 10. Now you'll remember I said to keep in the back of your mind this tissue factor. This tissue factor that gets exposed on the smooth muscle and fibroblasts. It's right there at the subendothelial collagen. This has two other names. This tissue factor also goes by tissue thromboplastin, and it also goes by factor 3. So that factor 3 is actually what we're looking at right here. What tissue factor or factor 3 will do is it will link up with factor 7, and it will become the 7-3 complex. So this is a 7-3 complex. Now it's important to realize that there isn't a whole lot of tissue factor in the area. It's just a little bit. So typically what happens, this isn't what always happens, but typically how you can think of it is that clotting starts over here. This is called the extrinsic pathway. And this part is called the intrinsic pathway. And the way I like to think of it is the E comes before I. So we're going to start with the extrinsic pathway. So the 7-3 complex will come down and it will activate factor 10, turning it into 10A. Now here's where it gets a little bit tricky, because factor 5 starts out inactive like the rest of them, but it actually gets activated by thrombin. We don't even have thrombin yet, so there's sort of a paradox on how factor 5 initially gets activated. So we'll just say factor 5 is already activated, and activated factor 5 will combine with factor 10. I guess now's a good time to explain that factor 2 also has another name, thrombin, or actually, I'm sorry, prothrombin, whenever it's factor 2. Factor 2A is thrombin. So factor 10 and factor 5A and 10A work together to activate factor 2 to 2A, which is thrombin. And thrombin's job is to convert factor 1 into 1A. What is factor 1? Factor 1, we saw, is fibrinogen. Fibrinogen, the thing that's linking the platelets together in primary hemostasis. It's thrombin's job to turn that into fibrin. Now, thrombin also has a few other jobs because it creates a feedback loop. So everything from 2 can go and do just about everything. It not only amplifies all of the rest of the pathway, but it also turns off the pathway. So factor 2 will go back and activate factor 5. It will activate factor 8. It will activate factor 7. it will activate factor 11, and there's another factor we haven't talked about yet, factor 13. It'll activate factor 13 as well. And factor 13's job is to do the cross-linking. So cross-linking fibrin. Now you can see here that factor 12, I haven't even mentioned how it works. That's because it probably doesn't do much in vivo. In the laboratory, it's the beginning of what we call the intrinsic pathway because it can be activated by negatively charged glass beads. So we have a glass bead that's negatively charged, and that will activate factor 12 to 12A, which will activate factor 11. But typically in vivo, it's probably factor 2 that activates, it's probably thrombin, 2A, that activates factor 11. So what happens, we get this initial activation down this pathway, but we don't have very much tissue factor. In fact, we run out of it fairly quickly. And so 2 comes back up, and then you start shooting down this pathway. And the intrinsic pathway is the pathway that amplifies the clotting cascade. Now everything that factor 2A, that thrombin, activates, I remember it like this, because if you remember I did, and I'm kind of starting over with a blank board because it was getting messy. I did 12, 11, my X was over here, and X marks the spot, 9, 8, and then I did 3 plus 7 equals 10, and then I did 2 times 5 times 1 equals 10. Now, first of all, the 2A, or thrombin, it can go back and activate, and the way I remember it is I count in reverse by the odd numbers. So I go 5, 7, 9, 11, 13, and then I just replace the 9 with an 8. So by activating all of these, thrombin will enhance the cascade, but it does something else. It gets swept down the bloodstream. So thrombin gets swept down the bloodstream, and when it does, it comes into contact with something called thrombomodulin. Thrombomodulin. And I just will imagine that thrombin kind of looks like this, and that thrombomodulin kind of looks like this, and so when they form together, they become a thrombin-thrombomodulin complex, and the job of that complex is to activate something called protein C. I'm just going to abbreviate it PC, but it's protein C. So this will activate protein C into an active form. When protein C is in an active form, it can combine with protein S, which is a cofactor. So protein S is simply a cofactor for protein C. And then protein C's job is to inactivate factor 5 and factor 8. So put 2 lines as inactivator, or just put an X. That's its job, inactivate factor 5 and factor 8. So I have thrombin, it's activated thrombin, it was prothrombin, but I had it activated by factor 5. And we know one thing it can do is it can lead to the inactivation of factor 5 and factor 8 through thrombomodulin and protein C and protein S. But something else it can do is it will stimulate an endothelial cell. So here's my endothelial cell. It will stimulate the endothelial cell to release TPA, tissue plasminogen activator. Now that we know that thrombin can activate or can cause the release of tissue plasminogen activator, or TPA, let's come back here and review. So we have fibrinogen, remember fibrinogen, linking these platelets together on the GP2B3A receptors. And then thrombin's job is to come here and make this twice as strong. And it will also activate factor 13, and factor 13 will come in and cause these to be cross-linked. And there's going to be more, so there's going to be cross-linking out here as well, and so it creates this meshwork, this like a spider web. So thrombin does all that, and in the meantime, usually plasminogen gets stuck like inside of this meshwork with it. So it's usually localized already here. So this is, we're going to call this plasminogen. And then tissue plasminogen activator will come and cleave this into plasmin. So plasmin's job, break all of this fibrin and all of the cross-linking, break it apart. That's its job. So not only does thrombin cause more coagulation, it also is the first step in inhibiting coagulation. And it's the first step in resolving the coagulation as well. And so part of what I wondered whenever I was learning this is how does where is it all? It's like a circle and it's defeating itself, but it's not. So how does the cell know what to do? Well, the cell, so I said that thrombin can cause the release. It'll act on the endothelial cell. So this is my endothelial cell, causing it to release tissue plasminogen activator. And it can also cause it to release something called plasminogen activator inhibitor. So plasminogen activator inhibitor actually stops the activity of tissue plasminogen activator. And it's actually the job of the cell. This cell is supposed to basically figure out how far it is from the clotting, the damage and stuff. And so it's going to be the state of the cell that decides what's favored and what gets released the most. And depending on that is going to determine the extent of the thrombus formation. There are other factors that inhibit the clotting cascade as well. For example, if you've heard of antithrombin 3, antithrombin. Anytime somebody says antithrombin, they're almost certainly talking about antithrombin 3. And so what should be known about antithrombin 3 is that it will inactivate almost every factor in the intrinsic pathway. And if you remember, 12, 11, we're skipping 10, 9, 8, and then 10. So every factor in this pathway can be inactivated by antithrombin 3, but it's usually very slow. It does it very slowly. In the presence of heparin, it increases the reaction rate differently for each of these, but for factor 10, it's about 500 to 1,000-fold increase in inactivation when heparin's available. And it's also important to know that this can inhibit thrombin. It can also do factor 7, but it's not very good. Even in the presence of heparin, it doesn't really inactivate 7 very quickly. So 7 can still keep going pretty strong. And that's why whenever you're giving somebody heparin, it's best to check if it's working by using the intrinsic pathway, and that's called the PTT. On the other hand, if you're giving somebody warfarin, factor 7 is the most affected, and so you check the extrinsic pathway, and that's called the PT. So heparin's job is to activate antithrombin 3, which impacts the intrinsic pathway. What does warfarin do? So for warfarin, we're going to have to go back to the coagulation pathway one more time, and we'll start with 10, 12, 11, skip 10, go 9, 8, and then 7. All of this, and then of course 5, 2, 1, all of this takes place on top of a phospholipid surface. So this is on a phospholipid surface, and it requires, remember I told you there was 2 things to store in the back of your mind. Tissue factor was 1. Remember that was factor 3. We already went over that. The other thing I told you to store in the back of your mind was that calcium is released from the dense granules. Every single one of these reactions takes place on a phospholipid surface. Where is it? It's the surface of the platelet. So everything is happening on the platelet, and it requires calcium in order for it to run. So let me show you. So let's say I have factor 7. And factor 7, whenever it's ready to roll, it's going to have this carbon right here, and this carbon is going to be attached to 2 carboxylic acids, not 1, but 2 carboxylic acids, which is very unusual for a protein. The way this second carboxylic acid gets here, vitamin K adds it, so vitamin K becomes an inactive vitamin K. And the reason we need these 2 carboxylic acids is because it allows it to chelate with calcium. And calcium is its cofactor. We'll come back to this vitamin K thing here in a second. So First of all, which of the clotting factors need calcium? Which of them need that what's called gamma carboxyglutamate residue? That would be factors 7, 9, 10, and 2. And also protein C. Remember, protein C was the one that would inactivate factor 5 and factor 8. It also requires calcium as a cofactor, and so it needs to have the gamma carboxyglutamate residue. Some people prefer to remember this as 9-10-7-2 or 1972. And that's fine as long as you remember that this 1 is really a 1 and a 0. It's the 9-10, or you could say whatever, 1972, so 9-10-7-2. But really, so 1972, they say that's the birthday for warfarin. Because I'll show you how it works in a second. But so let's say 7, 9, 10, and 2. Let's take a look at the phospholipids and the calcium. So here is my phospholipid surface. I have a phospholipid surface. This is the surface of my platelet. And I have activated factor 7 and tissue factor coming together. It would probably be better if I connected them. And they connect with factor 10 to activate it. When it becomes activated, factor 7 leaves, then tissue factor leaves, and then factor 2, so activated factor 5 will combine with 10, and it will activate factor 2. Now, all of this is calcium, so all of these calcium residues are needed in order for this thing to function. And so it's really important to remember that 2 things are required for the clotting cascade. One is a phospholipid surface, and the other is calcium. And so we go back to, in order for the calcium to get on there, we need vitamin K, and vitamin K gets used up. So we start with K, it becomes inactive vitamin K, and the only way it can come back to active is by vitamin K epoxide reductase. So epoxide reductase. And this is where we inhibit using warfarin and coumadin. So we just write right here, warfarin or coumadin. These both are basically inhibitors of vitamin K epoxide reductase. And so all of our vitamin K reserves get trapped over here in the inactive form, and you can't add calciums. You can't gamma carboxylate those glutamate residues, and when you can't gamma carboxylate them, they can't chelate to calcium, and so you can't, the clotting cascade stops like that. But factor 7, in that case, it has the shortest half. So all of factor 9, 10, 7, 2, these are all impacted the most. So you'll remember that factor 10 and factor 2 are part of this common pathway, but factor 9 is part of the intrinsic pathway. Factor 7 is part of the extrinsic pathway. So if you wanted to test if this was going, would you do a PTT or would you do a PT and test the extrinsic pathway? The answer is factor 7 has the shortest half-life, and because it has the shortest half-life, it becomes the most impacted whenever you use warfarin and coumadin. So in this case, a PT would be the most sensitive. And when I say PT, that includes INR. Now it's important to know that there are the 2 main anticoagulants, which are warfarin and heparin. Those are, and whenever I say again warfarin, I include coumadin with that. Those have been used for almost 80-90 years now, and newer anticoagulants are actually being developed. For example, inhibitors of factor 10A would be like rivaroxaban, and then inhibitors of thrombin would be dabigatran. So those just new things that are coming out, and I'm sure they're going to continue to be studied and stuff before they replace or completely replace heparin or warfarin. Now, you can have problems that cause either excessive bleeding, and that would be like the hemophilias. And so, for example, Hemophilia A, there's an A, B, and C, is a deficiency or loss of factor 8. So Hemophilia A or Hemophilia 8, and then if you just go backwards up the alphabet, Hemophilia B, Hemophilia C, defects in each of these factors. And we said that primary hemostasis, you usually have mucosal bleeding. With hemophilia, you bleed into the tissue, so you bleed into your muscle. So you got blood going into the muscles usually, and into the joints. And this usually occurs after a very, very minor injury. And not only are there problems with hypocoagulation, there's also problems with hypercoagulation, so you can have a hypercoagulable state. And these are classified as either genetic or acquired, so you can either have this problem or you can get it from, say, the medicine you're taking or the type of tissue or the cancer or something that you got. So I'm just going to give you the common ones and you can look up the other ones. The first one would be factor V Leiden, also just called a factor V mutation. It's not a deficiency, it's a mutation, and what it causes is the coagulation pathway to be overactivated. There's also a mutation in prothrombin, and these are the two most common genetically. And then secondary, you have broken up into things like myocardial infarction, atrial fibrillation, tissue injury, cancer, cardiomyopathies, nephrotic syndrome, and there's just so many that I couldn't possibly go over them all, but these are hypercoagulable states. Two that are probably going to be high yield are going to be heparin-induced thrombocytopenia, and the other one would be antiphospholipid antibody syndrome. So in the heparin-induced thrombocytopenia, what happens is sometimes people will take heparin. Heparin will get on the platelet, and it will alter the proteins on the platelet and cause antibodies to bind to them, and those antibodies will end up cross-reacting with several platelets and causing a platelet aggregation just by antibodies alone. So this will consume platelets, and so you can get thrombocytopenia during a prothrombotic state all at the same time. So that would be one example of DIC. Now, the antiphospholipid antibody syndrome, it's really interesting because what you have is you got your platelets and they have remember I said you need a phospholipid surface in order for coagulation to happen? The antibodies will actually bind and interfere. They will just block the phospholipid surface, and so whenever you take the person's blood and you test it in a test tube, it won't coagulate. So it looks in a test tube like it's an anticoagulant, but in vivo, it's actually a procoagulant. So that's why a lot of people with lupus will have this, why it was originally called lupus anticoagulant, but people who got it were hypercoagulable. So it's a sort of a misnomer. Alright, now that we understand the clotting cascade, we can talk about disseminated intravascular coagulation a little bit deeper. What is it? It's excessive activation of coagulation. So we already looked at one or two examples of that. In fact, we looked at the heparin-induced thrombocytopenia, and we also looked at the antiphospholipid antibody syndrome. So you end up with this thrombi in the microvasculature, which reduce platelets, fibrin, and coagulation factors. And then you have activation of fibrinolysis, which further reduces coagulation factors and fibrin. You can get a decrease in both the coagulation factors and in the platelets. So usually you're going to see a decrease in platelets because they're all stuck inside the microvasculature, and what you'll end up doing is you'll start bleeding from your mucosal surfaces. I remember when I told you when there's a problem with primary hemostasis, typically you get bleeding from mucosal surfaces. You can also end up with ischemia and infarction. So that's the big thing about thrombosis, is you get ischemia to the tissue where the blood's being blocked, and that causes an infarction or a death of the tissue. The pathogenesis is basically three-pronged. You can have a pathologic activation. So I'm just going to put pathologic once because all of these are pathologic. Pathologic activation of the extrinsic pathway. You can have a pathologic activation of the intrinsic pathway. You can have a pathologic decrease or an impairment in the inhibitors of coagulation. You can have endothelial damage. And really quick, I'm just going to circle some of these in different colors. So these three that I'm circling in blue are what we call hypercoagulable states. And Virchow has a triad on what causes thrombosis. So the last thing in Virchow's triad, if I can draw another line, is impairment in blood flow, impaired flow. And I guess I could even put in here a pathologic activation of the primary hemostasis. That would be where like antibodies are binding to platelets and causing them to stick together. But Virchow's triad is the most popular way that people remember this. And Virchow's triad basically damaged endothelium, impaired blood flow, or hypercoagulable state. Under impaired blood flow, you can include both blood stasis and turbulence, and the reason you can include turbulence is if I have my blood flowing and it becomes turbulent right here, then I have laminar flow up to that point, and then as this comes back this way, it's going to create an area of stasis, and that area of stasis can allow for a thrombi to start to form. The hypercoagulable state, we looked at several of those. I'm going to point you to Robbins. Big Robbins has a huge list of things that cause both bleeding and thrombosis as far as we look at the clotting pathway. Damage endothelium, we can look at inflammation, certain infections. You have even certain intracellular infections. And just TNF in general will damage endothelium. Impaired blood flow, think heart failure, think bed rest, think person immobilized, think any type of murmur that can cause a blood stasis pocket, and think atrial fibrillation. That is just coagulation in general. For DIC, now specifically for DIC, it needs to be coagulation in the microvasculature. It can be coagulation elsewhere, but it specifically needs to be in the microvasculature because you have way more microvasculature than you have macrovasculature, and you need it to get in the microvasculature because DIC, you want to consume as many platelets as you can, so you need a lot of space for that. And I should rephrase that. You don't want to consume platelets. That's a bad thing, but DIC, this disease, wants to consume platelets. And I should say also specifically for DIC, Robbins actually says that it's primarily two factors. So they say primarily two factors, and the first one being tissue factor release, and the second one being the endothelial injury. So you wouldn't really expect a DIC from, say, bed rest, for example. And this will probably give you 90%. I really don't know. It'll probably give you 90% though, but I can, off the top of my head, think of a couple other things that you get DIC from that has nothing to do with endothelial injury or tissue factor release. And what I'm thinking of is autoimmune diseases. So that just is antibody mediated. You can think, yes, possibly that TNF is causing some release of tissue factor and endothelial damage, but primarily in autoimmune, what I'm thinking of, it's just the platelet cross-linking from the antibody. Now, what can cause DIC? There's a lot of things. I've listed some. Pregnancy complications, carcinoma, aneurysm. Giant hemangiomas are a rare one that can cause it. Sepsis is a big cause. Trauma, intravascular hemolysis, for example, malaria if you're in third world type countries. And this one is a big tester on exams and stuff, is rattlesnake poison. So on a test it might say something like, hey, a kid got bit by a rattlesnake, what do you expect the platelet count to be? And you're going to pick just the lowest one. Now the clinical picture you're going to get from DIC is going to depend on where you find clots forming. And they can form anywhere. It's going to depend on the specific cause of the DIC. But if you see it in the brain, of course you're going to see neurologic problems if you have microinfarcts all over your brain. If you see it in the heart, of course you could get an MI from that. Lungs, you might have problems breathing. Kidneys, you might have kidney failure, problems creating urine. You might end up with retaining water and getting generalized edema. And so just keep in mind the clinical picture is going to be different for first the cause and second the location. So it's going to depend on what is causing it and where it's happening at to what you're going to see in the clinic. But in general, if it's an acute DIC, you're going to see the problems that you have from reduced platelets, which is bleeding from mucosal surfaces, and you're going to see the impairment in a specific organ system that has a bunch of microinfarcts, and it might be multiple organ systems. A chronic DIC is going to have even less specific, and so I'll show you on the next slide. So if we take a look at the lab values in DIC, acute versus chronic, you'll see, like you would think in DIC, everything would be abnormal, but in chronic DIC, everything isn't abnormal because the body has time to compensate for things, and so the one thing that you always see that's abnormal is an elevated D-dimer. Elevated D-dimer is seen in both acute and chronic, and so this is the most sensitive test you can do initially for DIC. But if you think through acute, you're getting massive clotting really quick, so you're going to use up platelets. You're going to use up your clotting factors and your platelets, so you're going to end up with an increased pro time. You're going to end up with an increased APTT. You're going to end up with an increased thrombin time. And then you're going to have reduced fibrinogen. All your factors are going to be reduced. And your degradation products from fibrin are going to be elevated. But if it's a chronic thing, then your liver is going to have time to compensate, and your bone marrow will have time to compensate and start pumping stuff out faster. And in that case, the clinical picture will vary. Now, as a last pathology tie-in, something that you'll also probably see in the lab values is if you're in the microvasculature and you get a thrombus formed, and then you have your red blood cell coming through, the red blood cell will come across here and it will become sheared. And then whenever you get look at it on the microscope, it's going to look something like that with little knobs down here in the corner, and this is called a helmet cell. So you'll get helmet cells with the shearing of red blood cells inside the microvasculature.